Okay, my dear colleagues, it's very hard for me to have a speak in this conference. You know that we had two earthquakes in Turkey and in North Syria, which affected more than 13 million people, and the 10 cities, which means that it's approximately 10% of the area of Turkey. We have more than 20,000 deaths by yesterday, and the death toll rises. We are not sure about the total number. We expect that it will be more than 30 or 40,000. So it's very hard to be here. But as head of scientific committee, I wanted to have my speak and share my experience with you in this situation even. The topic that I will cover today is therapeutic nihilism or nihilism, as it's said, in management of patent ductus arteriosus. We all know that ductus arteriosus directs ventricular output flow from lungs to placenta through aorta in intrauterine life, and it is accepted as physiological in first few days of life. But this first few days lacks a clear definition. You know that PDA is the most commonly diagnosed cardiovascular condition in preterm infants, and it is associated with increased mortality, especially in preterm infants, and results in harmful long-term outcomes. What are the consequences of PDA? The circular pathway of blood through PDA creates one, pulmonary overcirculation, and systemic hypoperfusion with ductal steal. What does it mean? With the increased pulmonary overcirculation, we observe pulmonary edema, we observe pulmonary hemorrhage, and there is an increase in need of respiratory support, which in short term results in bronchopulmonary dysplasia in addition of the pulmonary hypertension. What about ductal steal, which causes systemic hypoperfusion, results in risk of intraventricular hemorrhage, hepatomegaly, risk of necrotizing enterocolitis, and renal ischemia, which results in acute tubular necrosis. We know that although PDA has been reported to be associated with many adverse outcomes, its treatment has not led to decrease in outcomes such as BPD, necrotizing enterocolitis, and long-term neurodevelopmental outcomes. And in addition to that, we all know that all treatment options, including non-steroidal anti-inflammatory drugs, catheterization, or surgery, all have their own risks and restrictions. You know that there are different approaches for the management of the PDA when we speak about the medical option especially. First one is prophylactic approach, which means that those patients are generally treated in the first 12 to 24 hours before their symptoms for PDA starts. There are very famous studies, including DTEC study, Therapeutic study from France, and now EPAR study, which uses paracetamol for early treatment of the PDA as prophylactic approach. We know that with this prophylactic approach, there is, yes, accelerated spontaneous closure, but in contrast to short-term benefits, there's also increased side effects related to early use of the drugs. And the studies could not show any long-term effect of this approach. The second and third approaches are early pre-symptomatic or late symptomatic approaches. What is the difference between them? Early pre-symptomatic approach generally depends on the echocardiographic criteria. And in the literature now we have some scoring systems which are available to help the physicians to have a decision on management of PDA. For the late symptomatic one, we generally wait for the signs or showing the hemodynamic significant PDA effects, which means that using echocardiography plus clinical signs. But hemodynamically significant PDA definition is not clear in the literature. And there are some recommendations going on between those choices. But recently, a new trend which appeared in the last decade and called as therapeutic nihilism or expected management or conservative approach rises. This means that letting the nature of PDA take its course. It depends on high spontaneous closure rates and no long-term effect of treatment choices in contrast to side effect profiles of the drugs used in management. What is therapeutic nihilism? It's a kind of skepticism regarding the worth of therapeutic agents, especially in a particular disease, or a disbelief in the efficacy or value of therapy, such as non-steroidal anti-inflammatory drugs, catheterization, or even surgery in management of PDA. Why there is a high interest for the conservative approach in the last decade especially. This study was a very important study, which was published in 2019 from United States, showed that by only defining what is hemodynamically significant PDA in their hospital, researchers have shown that there is almost 50% decrease for the need for management of the PDA, which means that in the first epoch, they had 40% of requirement for PDA treatment, whereas only by giving a definition, they decreased this to 20%. And also, these researchers showed that now they were treating more immature preterm infants. I mean, this was more frequent in babies between 23 to 26 weeks when you compare the babies to 27 to 29 weeks of gestation. But the first famous study about the spontaneous closure of PDA in extremely low birth preterm, in very low birth preterm infants, below 1500 grams, was published in Pediatrics in 2017. This is a very important study which showed that in 85% of the non-treated infants, PDA closed before hospital discharge. Here you see two different figures. This one is according to birth weight. And even in babies below 715 grams, you see that there is increased rate of closure, which means that only around 20% of the patients had, for this group, 20% of the patients had open ductus before discharge, but in total, 85% have the closure. What about when you have a figure about gestational age? Here you see again there is a closure rate, except in a group which is below 26 weeks of gestation as birth gestational age. Even they also had an increased closure rate by time. This was slower. Later on, we also had some another studies, especially this one from South Korea was very interesting, which shows that the natural evolution of ductus arteriosus with non-intervention conservative management in infants born between 23 to 28 weeks of gestation. Here you see a population of around 200 patients. At the end of the first week, only 7% of the patients had closure for a group which was between 23 to 24 weeks, whereas this rate increased for the babies for 25 to 26 weeks, and when you come to the babies for gestation age 27 to 28 weeks, almost 80% of them had spontaneous closure at the end of the first week. But what was interesting in this study was that when you wait, you see that almost all patients had ductal closure by time. even including babies for 23 to 24 weeks of gestation. Only few patients were or had opening or had a requirement for catheterization or surgical procedure. This is an also important study by News et al. In this study was recently published in 2022, which showed that around 200 patients were followed with a gestation of generally with an average of 26 weeks of gestation. What was important in this cohort that 91% of the patients were below 26 weeks of gestation. And they showed that the spontaneous closure of PDA occurred in 91% of extremely premature infants, and only few patients were discharged with an open PDA and required ligation or catheter-based closure. In fact, we have a Cochrane meta-analysis which was published in 2020 about comparison of the early treatment versus expected management. And this study, although including very old studies from starting 1980s, demonstrated that no difference was observed for all-cause mortality and other important outcomes such as surgical need for the PDA, chronic lung disease, severe IVH, and necrotizing enterocolitis between two approaches. And as you guess, patients who receive early treatment or medical treatment have higher risk of side effect profile for the drugs when you compare to expectant management. What about long-term neurodevelopment outcomes? The first study was published in 2019, and this study was from Japan. Although it was including a small sample size, this one showed that there's no difference between the groups when you follow them for up to 5 years of age. Another study, again, which showed the neurodevelopment impairment at 2 years for the baby who have prolonged exposure to PDA. This was also an important study which showed that when you compare the exposure duration for the babies who have 22 days and 59 days, there was no difference for the long-term outcome. So conservative management may be a reasonable option, was their suggestion for this group. But the most famous study, which was named as PDA Tourist Study, was published in 2019, earlier in the February of 2019. This study included many NICUs all over the world, including Sweden, United States, Scotland, and 2 centers. One of them was our unit, Ankara University, also participated in this study. By the way, this is Turkish map. Here is the huge area of the earthquake, including the north part of the Syria. I mean, here we have 10 cities with more than 13 million people. Let's come back to the study. This study was a very important one. This study did the first evaluation of echocardiography for the PDA at the end of the first week, and later on randomized the patients to early treatment or to expected management. Here you see that patients for the below 26 weeks of gestation who had early treatment had accelerated spontaneous closure. At the end of the 6 weeks, we have same closure rates. This was again similar for the babies, equal or greater to 26 weeks of gestation. Here you see that there's an acceleration of closure in early times, but at the end, there is no significant difference between the groups. This study taught us that in babies below 26 weeks of gestation with moderate to large PDA and who were receiving respiratory support after the first week, early treatment could not reduce PDA ligation or presence of PDA at the discharge. Early treatment did not improve any of the pre-specified secondary outcomes, and in contrast to that, it resulted in delayed full feeding and was associated with a higher rates of late onset sepsis and deaths in infants born greater than 26 or equal to 26 weeks of gestation. There were some, review about this study about that. This study could have a selection bias owing to the low enrollment rate of eligible infants and high rate of backup medical or surgical treatment for the management of PDA in expected group. So we published subgroup analysis of this. We had 3 more publications on these subjects. The first one was about the lack of equipoise in PDA Tourist trial. Yes, we showed that in patients who were treated in the first 6 days, we observed lower rates of respiratory morbidity. So what about the BPD? Later on, we had a conclusion about BPD, and this study was published in 2022 in Journal of Pediatrics about the prolonged tracheal intubation and the association of between PDA and BPD, a secondary analysis of the PDA Tourist study. What was interesting that if infants required less than 10 days of invasive ventilation, which means intubation, moderate to large PDA was not associated with increased risk of BPD. In contrast to that, if you have a moderate to large PDA, and in addition to that, the patient is intubated and had an invasive ventilation equal or more than 10 days, there is an increased risk of moderate to severe BPD. Later on, through a couple study researchers from France, they also had a subgroup analysis, and interestingly, they also gave the same number. 10 days is very critical for the development of BPD in patients with PDA, which means that if your baby is intubated still, you have a high risk of BPD. Although it's not published, the subgroup analysis of our study was not published. The Turkish study, which is the largest sample of PDA in the literature, showed that we had also a similar subgroup analysis for inter-PDA trial. Again, our study showed that 10 days is very critical for the development of PDA in association with the intubation of the patient. Another randomized controlled trial, again from the same group from South Korea, was published. This study was also a very good study for the patients between 23 to 30 weeks of gestation who had a significant PDA, and the patients were between 6 to 14 days. They screened approximately 400 patients. Later on, if the patients had PDA, they firstly had cohort for the babies between 23 to 26 weeks and 27 to 30 weeks. And later on, they assigned their groups to the oral ibuprofen or expected management and follow up their results. This study is a very good study, a recently published one last year. Here, you see the figures of the study. It's very interesting that here, there's a total population. You see that non-intervention and ibuprofen group have the same closure time, a closure rate by time. For the babies between 23 to 26 weeks, again, this is similar. But in babies between 27 to 30 weeks, the ibuprofen, oral ibuprofen, only accelerates the closure, but at the end, they have the same closure rates. So, this group said that the non-intervention approach is similar, is non-inferior to oral ibuprofen treatment in reducing also the incidence of BPD and death in preterm infants. However, they concluded that they could not show the effect of oral ibuprofen maybe in closing PDA, especially in babies between 23 to 26 weeks, because we know that also response of the babies to medical treatment in this age is not so good. And this is our study. Our study is, as I told you, that the biggest one in the literature. This was published again in 2020 in journal in Frontiers Pediatrics. We enrolled approximately 1,200 patients with a mean of 26 weeks of gestation and around 900 grams of birth weight. We showed that 46% of the patients had moderate to large PDA. For the management of these patients, interestingly, we also was surprised about that. In Turkey, 24% of the infants were managed conservatively, whereas 76 of them had medical treatment. So we compared those groups and we showed that medical treatment did not show any reduction in the rates of open PDA at discharge, surgery need, or prematurity related secondary outcomes. In contrast with that, early treatment, which means that treatment of the patients in first 7 days, in the first week, was associated with higher rates of mortality and BPD and death. Also, the rates of necrotizing enterocolitis, BPD, and ROP were higher in infants born equal or greater to 27 weeks of gestation with moderate to large PDA. So we showed that early treatment also resulted in increased side effect or long-term consequences. So as a conclusion, I can say that there has been a shift from aggressive treatment toward a more conservative management in the last decade, because we know that there is a substantial rate of spontaneous closure of the ductus arteriosus, even after failed pharmacological treatment, which has been shown in many studies. Since pharmacological treatment is not associated with an improvement in overall outcome, people think that fragile preterm infants are withheld from possible adverse effects of the pharmacological intervention. This is why the new trend, named as therapeutic nihilism, expected management, or conservative approach, rises. But treatment seems to only accelerate closure of PDA without improving outcomes. But still, we need some randomized control trials, especially including babies between 23 to 26 weeks of gestation with signs of hemodynamically significant PDA, because those are whom have respiratory support, which is more challenging, and the risk of BPD is higher. Just a few months ago, I was ending my speak with these studies, and I was saying that we should wait for the results of 2 studies. One is Benedictus studies from Belgium, Netherlands, and Denmark in Europe, which compares early treatment in the first 3 days to the exposure to expected management. The other one is a famous one, which was started 10 years ago, named as Baby Oscar trial. Baby Oscar trial again has a similar diagram for the randomization. The Baby Oscar trial has not been published, but has ended. And I know from my dear friend Samir Gupta, he presented the results in a conference, which we had a speak together. He also showed that they could not show any effect of early treatment on in short and long term when you compare to expected management. We are so lucky for this speak because the results of Benedictus study has been just published few weeks ago in the New England Journal of Medicine as expected management of early ibuprofen or early ibuprofen for PDA. Here you see that around 136 patients in expected management with 137 in the early treatment group, which means that patients treated in the first 3 days, depending on the echocardiographic criteria for moderate to large PDA patients, were compared. And here we say that in babies below 28 weeks of gestation. Expected management for PDA was non-inferior to early ibuprofen treatment with regard to necrotizing enterocolitis, moderate to severe BPD or death, and results suggested a lower risk of outcome for the expected management group because they do not face the side effects of the drugs. So in conclusion, I can say that the trend in management of PDA is changing. The expected management rises in many NICUs, and now we have a discussion about to treat or not treat the PDA, and we need some more data about the babies, especially between 23 to 26 weeks of gestation, which PDA management can affect the short and long-term respiratory morbidities. Thank you very much for your attention with some photographs from my unit, Ankara University School of Medicine.